Welcome, everyone. After we discuss the paper by Dr. Bill Mastro's group in North Carolina, we're going to continue with an e-testing and a little bit different paper, but on the same area, by Dr. Adam Godes, who works with our good friend Stephen Black in London. And today, as our discussion, have well-known star, Gus Desai. Adam, please take it on.
Okay. Just checking that you can see my slides.
Yep.
Perfect. So, well, I'd like to thank everyone for giving me the opportunity to actually present this paper, which was published last year in JVSVL. And it was very much a collaborative effort between the hematology and the vascular surgery team at St. Thomas's Hospital. So what do we know about inherited and acquired thrombophilias is that they increase the risk of VTE and specifically antiphospholipid syndrome, which is an acquired thrombophilia, is associated with an increased risk of recurrent VTE. As a result, iliofemoral venous stenting in patients with thrombophilia is considered controversial. So the aim of this study was really to examine the association of thrombophilia with cumulative patency and reintervention rates following venous stenting in chronic post-thrombotic patients. So just to start, this is the anticoagulation protocol that we have postoperatively at St. Thomas's Hospital. So in patients without thrombophilia, we use 2 weeks of low molecular heparin postoperatively. This is transitioned into vitamin K antagonist if there are no complications. And then following that at 6 months, we transitioned into a direct oral anticoagulant. And then this is stopped at 1 year. For patients with an inherited thrombophilia, the protocol is very much the same. However, at 1 year, we have an MDT discussion along with a discussion with the patient to determine whether anticoagulation continues beyond 1 year. The difference really is those with antiphospholipid syndrome, since we know that there's recurrence of thrombosis in patients on DOACs from the Pengo et al. Paper in 2018. Our protocol is such that we transition patients at 2 weeks onto a VKA, and this continues on lifelong. So the methodology very much was that we were looking at consecutive patients over a 5-year period. These were treated with nitinol venous specific stents. They all had post-thrombotic occlusions with a minimum of 18 months follow-up. Thrombophilia testing occurred if patients were young, had unprovoked DVTs, had strong family history for VT, and had VT recurrence. So these were all guidelines that were set out by the British Journal of Hematology in 2010. Postoperatively, they received anticoagulation as I described, and our ultrasound surveillance program occurs at the following time points. Reintervention occurred if the stent diameter reduction occurred at greater than 50%, or if the stent was occluded, and this was associated with recurrence of symptoms in patients. So what did we see? Well, this is a Kaplan-Meier analysis of the reintervention rate for patients with a provoked DVT, seen here in blue, and an unprovoked DVT, seen here in red. And as you can see, out to 30 months, we don't see any significant difference in the reintervention rate between these two groups. Now, this phenomenon was consistent as well for cumulative patency. Looking at the same two groups out to 30 months, we did not see any significant difference in cumulative patency. Now, looking exclusively at the unprovoked DVT group, so these are patients that all received thrombophilia testing, and we divided them into those that tested negative for thrombophilia, which was seen here in black, and the controversial group, the ones that tested positive for thrombophilia, seen here in blue. This again is a Kaplan-Meier curve of the reintervention rate. And here again, we see no difference in the reintervention rate out to 30 months. And again, this is the same for cumulative patency out to 30 months between patients with thrombophilia and without. So what are the key findings? Well, we looked at 136 patients that underwent deep venous stenting for cross-thrombotic disease. 52% of these had an unprovoked DVT and were tested for thrombophilia. Keeping in mind, we're a national thrombophilia or national referral center for antiphospholipid syndrome, and as such get a lot of thrombophilia cases. 47% of those patients had either an inherited or an acquired thrombophilia. And cumulative patency was not any different between patients with a thrombophilia or without. So what's the take-home message? Well, patients with thrombophilia should not be excluded from venous stenting after PTS, provided that appropriate peri and postoperative anticoagulation therapy is given. So what's our recommendations for postoperative anticoagulation? Well, it's about asking the question, does the post-thrombotic patient meet thrombophilia testing criteria? If they don't, then we follow very much the same protocol as someone not having thrombophilia, and we stop anticoagulation at 1 year. If they do meet the criteria, the only relevant test is to determine if they've got antiphospholipid syndrome or not. If they don't, we treat them out to 1 year and then have an MDT discussion, again with hematology as well as the patient, to determine if anticoagulation needs to continue. And if they do test positive for antiphospholipid syndrome, we transition them on at 2 weeks following low molecular weight heparin to a VKA, and this occurs lifelong. So thanks very much.
Excellent, Adam. Very nice presentation. Interesting findings. I will have Kus now to start the discussion, and we'll move on.
Adam, actually, so I think these kind of papers are very important because they challenge biases. One of the biases that's out there in the vascular endovascular community is that, everybody, if they have a clot, needs, hypercoagulability testing. And this directly challenges it because your outcomes, in fact, your KM, even though not necessarily exactly significant for it, showed better patency in the thrombophilia group than it did. Obviously not significant, but something worth noticing. So clearly there isn't any inherent bias in your work or your data set. What I would ask is, if you don't know somebody's antiphospholipid, so you're a referral center and you're going to know many times, but let's say you have the de novo patient coming in through the emergency department, you treat them. What triggers an investigation for antiphospholipid antibody, for looking for those antibodies specifically? What clinical occurrence or finding triggers that workup?
Thanks for the question. So, I mean, as you point out, I think of the thrombophilias that are important, really, it's just antiphospholipid syndrome. So the question then becomes, as you pose, what constitutes a test? And so we very much follow the criteria that was set out by the British Journal of Hematology. And it's that if you see patients that are young, if they've got a history of VT recurrence, if they don't have any provoking factors, so they've essentially got an unprovoked DVT or a strong family history, then that warrants testing. And of the tests that are considered relevant, really, it's just for antiphospholipid syndrome.
Right. So a failure, despite being on optimal medical management, should then trigger the next set of questions and then potential workup.
That's correct. Yeah. And that's how we treat patients at St. Thomas. It's exactly that way.
Excellent.
Yeah. Adam, what is interesting, myself and many others done work on the impact of thrombophilia altogether. And what we found, actually, contrary to what I used to believe, that thrombophilia is important, it seems even for recurrent DVT or PE or anything else is not as important. Mostly because we found in our, one of our papers in 2010 in Annals of Surgery that the weak factors are predominant and dilute the effect of the important risk factors. And if you look at the literature or VT literature, basically the ratio is about 8:2 or 9:1 of weak versus strong factor, and that's why it's dilution. Now, in your center though, because you're being a center of reference and having like good hematology department there, you have more than 50% of your patients with significant risk factors, for thrombophilia, strong factors, which in my opinion should have turned the table around. But I was nicely surprised to see that your findings are actually were good on either group, like Dr. Desai, the Kus told us. So what do you think is that? What are you doing there that's different, that, as I said, it's surprising to find that anyway, but it's a good news though.
No, thank you. So I mean, your 2010 paper in Annals there, that really did highlight the sort of factor and the dilution effect. I think, we very much are a national referral center, so we do see a disproportionately high number, and that always is something to keep in mind. And really, of the thrombophilia cases, 50% of the ones that were positive for APS. Again, a very disproportionately high number of APS cases. I think what we have that works in our favor is that we have a very sort of consistent anticoagulation protocol. And we use low molecular weight heparin for 2 weeks, and this is post-operatively. And we've presented previous data that actually shows that 50% of all our reinterventions occur early. They occur within the first 2 weeks. And so maintaining that low molecular weight heparin, being able to intervene rapidly and consistently across groups, I think give us favorable outcomes in the thrombophilia group. And I think because as well as we adopt a very specific anticoagulation protocol for the antiphospholipid group, which is clearly the standout group, I think that gives us good patency rates overall as well, because we are treating these patients appropriately with the right anticoagulation at the right time. And that's giving us an advantage there.
And if anything, what your work has done, it has negated all the other biases and variables that might impact the outcomes in a relatively small cohort. I mean, not to minimize your work, it's difficult to get large cohorts of patients like this, and we any of us would have difficulty. So it's really well done. But what I want to drive home is that you have basically, through your work, negated, or I think in my view, done a good job of negating the biases and the concerns. And so then it comes down to the disease, and the disease is the only variable. Then they're all treated the same. And so then you can really parse it out. Otherwise, you're left in this sort of weird state of equipoise. So it's very important work. And I think it confirms that we need not worry as much about the other thrombophilias as much, and really start thinking solely about APS, which of course is a very distinct disease state. So, but I think we're ready to wrap up, right, Nikos?
Yeah, a small comment at the end, which is not clear on your paper. I presume that any patients with recurrent VT events and those having more than one thrombophilia factors together, I assume you treat like, I guess, for life. Is that correct?
That's correct. Yeah.
Perfect.
That's correct.
Adam, thank you so much. That's a great work, and please continue.
Thank you, guys.
Good people like you.
Thank you very much, guys, and I really appreciate the opportunity.
You're welcome. Enjoy.
Pleasure to be with you.
Take care.
All right, take care.
Thank you.